First, I'd like to thank you all for coming to the first patient information support meeting for bladder cancer. It really means a lot to me and to many of the Bladder Cancer Canada members. Lastly, I'd like to thank all the patient survivors from Bladder Cancer Canada who are really the motor behind this effort and has put this to another level. Thank you again. So for the next 30 minutes, I'm going to try to talk about bladder cancer from the basics to a bit more complex issues. So for patients who are newly diagnosed or not familiar with the disease, some of the basic parts of it, and for patients who've been through the journey, some a bit more details of it. And then we'll feel free to ask questions either at the end of my talk or towards the end of the session. So let's proceed. So just first and foremost, to talk about bladder cancer, let's talk about a bit about where the bladder is. So if you look at, this is a human body, we both have two kidneys, and that's where urine is formed. So urine travels from the kidney down in what we call these tubes, the ureter, and that ends where the bladder is. So the bladder stores the urine that is excreted from the kidney. And then sooner or later, everyone goes ahead and urinates through the urethra. The urethra is the tube that, the passage that leads the urine to go outside the body. And in men, if you look here, the prostate hugs around the urethra. So any diseases that afflicts the bladder or the prostate, you'll have symptoms of urination, such as frequent urination, the urge to go to urinate, blood in the urine, all these symptoms that we're talking about. So bladder cancer, what is the statistics in Canada? And that's similar in the States. Bladder cancer among men is the 4th most common. Among women, it's in the 10th most common cause of cancer. And it is one of the top 10 leading causes of cancer-related deaths. If you look at the stratification of incidence of bladder cancer across Canada, it varies across provinces, but not significantly. The only difference, if you look at Ontario here, it's reported to have much less bladder cancer than other provinces. But this is mostly a reporting issue because they don't count carcinoma in situ, which is a type of bladder cancer, into their numbers. If you look at the population-based studies in the States, over the last couple of decades, bladder cancer, the incidence of bladder cancer, has not increased that much. And when you look at the cure rates for bladder cancer, if you look at cancer that has not penetrated outside the bladder, the cure rates are very good. But once you have cancer penetrating outside the bladder muscle wall, the cure rates become lower and lower, particularly when you see them distantly in the lungs or lymph nodes. So the interesting thing is the prevalence of bladder cancer is 10 times its incidence. That means that for new diagnosed bladder cancer every year, there's approximately 10 that are already living with bladder cancer. And if you look at on per patient basis from the diagnosis till death, interestingly, bladder cancer is actually the most expensive to treat. Here's some interesting numbers. The chance of developing bladder cancer among men throughout their lifetime is approximately 4%, and that's similar to Canada or the States. The chance of a woman developing bladder cancer is 1%. And partly because there's less women smokers than men smokers. But what's interesting is, if you look at cervical cancer, and you ask people about cervical cancer, many people know about cervical cancer. When you talk about bladder cancer, not many people know about bladder cancer. And the most common question they ask you, well, is this they refer to it as the gallbladder, which is in fact the urinary bladder. And what's even more interesting is bladder cancer kills more women than cervical cancer in the States and in Canada. Lastly, although there's a slight trend towards improved survival in bladder cancer patients, this has not changed much over the last couple of decades. So what are the risk factors for bladder cancer? What puts you at risk of developing this disease? Well, first and foremost, as you grow older, your risk increases with developing bladder cancer. The most important risk factor is actually smoking. Smoking is the strongest risk factor to increase your chance of developing bladder cancer, similar to lung cancer. These are actually the two cancers that have the strongest risk factor of smoking among the other cancers. And what's interesting is it's not just the risk factor to develop bladder cancer, But also, once you've diagnosed bladder cancer and treat it, it's a risk factor for cancer to come back as well. Occupational exposures is important. Many compounds, namely they're classified as aromatic amines, they're present in people who work in the paint industry, the rubber manufacturing, petroleum. All these occupational, what we call occupational hazards that increase slightly the risk of developing bladder cancer. Patients who receive this compound, cyclophosphamide, this is a chemotherapy agent that is commonly used in treating certain cancers such as breast cancer. It increases your risk of developing bladder cancer as well. And of course, family history. If you have several relatives that have bladder cancer, your risk is slightly increased. And if you yourself have bladder cancer in the past, your risk is higher than the general population of having bladder cancer in the future. But what's important is many bladder cancer patients don't have any of those risk factors. So what is the most common symptom of bladder cancer? It's actually blood in the urine. If you see blood in the urine, you need to go to your doctor to have it checked out. Very important. Other symptoms that can happen is, as we talked about, frequent urination, the urgency that you always have to go and urinate. If it's severe enough, you can go what we call urinary retention, where you're not able to pass urine at all, requiring a catheter to put in and drain your bladder. And some people can have burning when they urinate. A lot of these symptoms are associated not just with bladder cancer, but with other pathologies such as what we call benign prostatic hyperplasia, I can call that. But whenever you have blood in the urine, always think that we need to go to the doctor to make sure nothing ominous is present and underlying. To diagnose your bladder cancer, there's a few things that we do as physicians. First, we do a physical examination. We feel the abdomen for any masses. Then, we do what we call a urine cytology. Urine cytology is we ask the patients to collect urine in a container, and that's sent to a lab where the pathologist, who's a physician that looks at cells and tissue, examine the urine for abnormal cells. And sometimes you see cancerous cells in the urine. Now, this is a great test. The problem is sometimes bladder cancer is present without having a positive urine cytology test. So it's not all the time sensitive. The other thing we do is we want to make sure the kidney function is okay with blood tests. And we image the belly to look at the tubes that drain into the kidney, because those tubes can be affected sometimes with the disease. And lastly is what many of you are familiar with, is cystoscopy, where we take a camera and look in through the natural passage into the bladder to evaluate and make sure that there's no tumors in the bladder. And lastly, a rectal exam. The rectal exam basically feels the prostate to make sure if there is bladder cancer, it's not invading into the prostate. Once we see a bladder tumor, what we do is we take a biopsy. And a biopsy is done under anesthesia, where we scrape the tumor out and send it to pathology. And the reason we do that is to find out the type of bladder cancer you have, if you have any, and what we call a stage, which is the extent, how deep is that tumor going in the bladder. And this dramatically influences what we're going to do to the patient in the future. If you look at the stage, which is the extent of the disease, what we call superficial bladder cancers or non-muscle invasive bladder cancers are the early stages, TA, only in the lining, or T1, which is just underneath the lining. If you have tumors that are in the muscle wall of the bladder, the muscle wall is right around, surrounding the lining of the bladder, this is T2. If you have tumor in the fat, which is outside that muscle wall, this is T3. And this is where basically we say that the cancer has penetrated through the wall into the surrounding fat. It's just a bit of an overview because it really influences what we do to patients in the future. So, if you look at epidemiologically, 3/4 of the patients who have bladder cancer have what we call superficial bladder cancer, which is cancer that's not going through the muscle of the bladder. Now, these tumors, many of them are not life-threatening, the majority are not, but they tend to recur. So they recur in 50 to 70%, depending on what studies you show, but they recur often. But only the minority are life-threatening. The other class of tumors is when the patients present and they already have invasive disease, meaning that the cancer is in the muscle of the bladder. Now these tumors are life-threatening, and they need to be addressed on a more urgent basis. So when we look at people with bladder cancer, how do we like to reduce risk stratify them to see who are the bad players, who are the good players, to help decide what we're going to do. And how do we risk stratify those patients is by looking at the tumor's characteristics under the microscope. One is the stage, which is the extent, how deep it goes, as we talked about. Two is the grade. And the grade is important because the grade tells you how aggressive is the cancer. So how differentiated, how aggressive the cancer is the difference between a low grade and a high grade. Now, it's different if you have one tumor versus 10 tumors in the bladder. That also is important to know. And the size. A half a centimeter tumor versus a 5 centimeter tumor, they behave a bit differently. So based on these criteria, we stratify the disease into low risk, intermediate risk, high risk, very high risk, to help guide what we're going to do next. And this stratification is mostly used for the non-muscle invasive bladder cancer, which we'll talk about the treatment in a bit. Every time you have a scraping of the bladder, you notice that your physician says, okay, we're going to do a cystoscopy to look at your bladder in 3 months. And that's very important because that tells you if in 3 months you don't have a recurrence, your chance of having recurrence is much lower than patients who have a recurrence in such a short period of time. Cystoscopy, this is basically, whoever is not familiar with this test, I'm sure many of you are, it's basically a camera that goes through either the penis or the urethra in a female to look in the bladder. And the resection is this camera has a little loop that scrapes that tumor off, and we take it, pluck it, and put it in a container to send to pathology. Now there has been a few studies trying to improve the quality of that resection to try to pick up as much tumors as possible, sometimes not visible by the eye. So there's several studies looking at, this is one example, looking at basically instilling a medication in the bladder to give the tumor a different color. This is what we refer to as blue light cystoscopy or fluorescent cystoscopy. If you look here, this is the regular stuff, but when you instill that solution and do cystoscopy after, you easily identify this tumor. So it improves detection. Similar here, this is the tumor in the regular cystoscopy. It's not very obvious. With the blue light, it becomes a bit more obvious. Again, there's several studies looking at this, trying to see if we can make that the standard of care or not. Right now it's not, but studies are really accruing to better evaluate this in multiple centers. Similar here, look at this here, it's not obvious. You look at it here, it's a bit more obvious. Okay. And this is another way which we're actually using now at our center in the study, looking at when you evaluate with a camera, you use certain wavelengths. So this is basically what we call narrowband imaging, where you use a certain wavelength that accentuates the tumor vessels and helps maybe detect tumors easier. If you look, and this is without instilling any solution, it's just basically playing around with the software, trying to identify higher resolution with optimal wavelength to detect tumor. If you look at this using that narrowband imaging, this tumor is much more obvious than this. And these kind of technologies actually have been used in looking at gastroscopies, for example. It became standard with gastroscopies, and now we're looking at it in bladder. The other aspect is when you have non-muscle invasive bladder cancer, is we aim, as I told you, there's a lot of recurrences, around 50 to 70%, so we try to decrease these recurrences. And how do we do that? By trying to give some treatment in the bladder, either a chemotherapy treatment or an immunotherapy treatment that will help decrease recurrences and progression. So the goal is you want to decrease recurrences, You want to prevent progression. So the difference between those two is progression is you want to prevent the tumor when it comes back, that it comes back deep. That's the key. And you want to take away any residual disease that is not seen by the eye. Some patients may have experienced a chemical that was given right after surgery to scrape the tumor. This is what we call, you probably see either called biomycin or epirubicin. These are basically a one-shot chemotherapy dose that's given right after the resection, and it's meant to decrease the recurrence of the tumor. Because the theory is, once you do a biopsy, a lot of the floating cancerous cells can re-implant or get stuck one more time on the bladder, causing recurrences. So if you get a good one shot of chemo in the bladder, that may eradicate this. And what's different is the chemo in the bladder is not the chemo that everyone's familiar, hear about, where people lose their hair and get sick. This is the chemo where you give intravenously. But chemo in the bladder, you don't have these effects. They're local effects, what you have. Next. And next. So these are the chemo agents that we commonly use. The most commonly used agent in Canada and North America is that what we call mitomycin C, and the other second most common is called epirubicin. So that's an interesting. So BCG is the what we call is the gold standard in terms of the intravesical treatment in the bladder, because it's the only one that impacts not just recurrence but progression of disease. What's interesting about this agent is actually it's the same bacteria that's used to vaccinate against tuberculosis. What we do is we give it in the bladder to boost up the local immune system in the bladder. And that's been clearly shown to impact on the progression of the bladder cancer and actually recurrence. Typically, when we give this, we give it on a 6 weekly treatments, followed by what we call maintenance, every 6 months for 3 years. And again, just to emphasize, that's the only agent right now used currently that impacts on progression of disease compared to the chemotherapeutic agents. Many people who are under this treatment can have side effects of this treatment, such as frequent urination, urgency, they can develop fever. Sometimes the side effects are so severe that we have to stop the treatment altogether. So it's not really benign. There are side effects of the treatment, but because the benefits outweigh the risks, we routinely advocate for patients who will call high risk of the disease coming back in an aggressive fashion. So for more information, we actually put up a Canadian guideline. It's actually free on the website, free on the Canadian Urological Association. I think there's a link to it on Bladder Cancer Canada website too, that talks about how do we treat and what are the recommendations for patients with non-muscle invasive bladder cancer. If you have any questions, I urge you to go ahead and show this to your physician. And basically, in brief, before belaboring the point, anyone who's low risk, basically has low-grade disease, very, very superficial, the recommendation is to give one shot of that chemotherapy I talked about right after the resection, and then follow. Anyone with high risk, the recommendation is sometimes to re-scrape that area and to follow by the BCG, as we talked about. 6 weeks, every 6 months for 3 years, ideally. If those treatments don't work, then the next step will be to remove the bladder completely. And we'll talk about it soon. So, let's talk about the next group of patients. The next group of patients are patients who present with muscle-invasive disease. Cancer that's deep in the wall of the bladder. And this is the potentially aggressive life-threatening disease that requires early detection, early treatment, and then let's talk about the options, what the treatments are. Here are the options. The standard of care basically is to remove the bladder completely. Sometimes we offer to give chemotherapy before removing the bladder, followed by removing the bladder. And sometimes, in certain patients where the tumors are not big, we can offer a combined what we call radiation with chemotherapy without removing the bladder completely. And I'll talk about each one invasive. Next. Okay. So if you look at survival, the cure rates of patients who undergo removal of the bladder, a lot will depend on how extensive is the disease through the bladder, is it outside the bladder wall, is it in the lymph nodes. The 5-year survival, if the disease is just in the bladder, it's more than 80%. But if it's in the lymph node, it goes down to 30%. So it heavily depends on the stage, what we call the extent of disease within the bladder and the lymph nodes. This is basically, it's reassuring when we looked at the, top centers in the States, such as MD Anderson, Lawrence von Kettering. This is from University of Southern California. Their cure rates, when we look at our Canadian series in tertiary centers, and that was just published actually a few months ago, they're pretty similar. So there's no real big difference. You're doing just as good job as anyone else. Next. So what does removing the bladder entail? For a man, it entails removing the bladder, the prostate, as well as the lymph nodes. For the woman, it entails removing the bladder, the part of the vagina, the ovaries, and the uterus. So it's a bit more extensive surgery for the woman. It also involves for both removing the lymph nodes, and at the end, it involves constructing what we call a urinary diversion to channel the urine because no longer the bladder is in place. The lymph nodes, we've shown this a few years ago, and we're advocating a lot over the last couple of years, is to really do an extensive removal of the lymph nodes because that's been shown to also improve the cure rates in the future. So to go back to our anatomy, kidneys excrete urine in the ureters, and that's the bladder where the urine is stored. So once you remove this bladder, these tubes need to be connected somewhere to divert the urine to the outside. Typically we use, each one has they have large intestines, colon, and small intestines. And typically what we do is we take a piece of the small intestines to connect the ureters to that piece, and that small intestines will divert the urine either to the outside, to the belly, or what we do is we can make a reservoir too. And let's talk about a few approaches. Next. So this is what we commonly call ileal conduit, which is basically you take a piece of intestine, you connect the tubes to it, and that intestine comes, a hole comes out on the belly where a bag collects the urine. This is what we call an ileal conduit. And this is a schematic of it. See the kidney, the ureter, they're connected to that piece of bowel, and this comes out on the right side of the abdomen. And this is basically how it looks like. Many people, you will not notice people wearing this because underneath the clothes, but the appliance that collects the bag, and that's covered by the clothes. And once in a while, every few hours, they empty the empty bag. That's what's called ileal conduit. The next one, which is much less commonly utilized in Canada, the States, and actually everywhere, is what we call an Indiana pouch, which is we make a reservoir where the patient, and the reservoir with a little conduit that comes to the skin, but that conduit doesn't leak urine. So the patient catheterize themselves every few hours to drain that reservoir. It's called an Indiana pouch, and many people don't advocate it that much because the complication rate of this pouch is much higher than what we call the Studer, which is the neobladder, which I'll talk about in a second. So this is the Studer, the neobladder, which is basically, again, a longer piece of intestine is configured into a sphere and a little tube. The ureters drain into that tube, into that sphere, and this reservoir is connected to the urethra, where the urine flows outside through the penis or through the urethra in the female. And this is another schematic where the ureters go here, there's the reservoir, and then it just comes outside. This is what we call a neobladder. Some patients, if their tumor is small enough and isolated, I mean there's only one tumor, we don't have to remove the entire bladder. What we can do is remove part of a bladder. But the truth of the matter, once you have patients with muscle invasive disease, only 5% of those patient population will qualify this procedure because they have a bit more extensive disease. And lastly is what we call the chemoradiation. And again, it's not fit for everyone, depending on the cancer, but if the cancer is small and not extensive, sometimes we offer a combined chemotherapy with radiation in an effort to save the bladder, not remove it. And that basically involves, mapping the bladder by X-rays on the outside and zapping the bladder with radiation daily for around 6 to 8 weeks. And typically, a patient will go in what we call a linear accelerator on a daily basis, where for a few minutes gets the dose of radiation towards the bladder and the lymph nodes. And in this, if you well select the patients, meaning you don't offer it to everyone, you offer it to patients that we think is appropriate, the risk of requiring the removing of the bladder in the future is roughly around 35%. So it's not perfect, but it's suitable for patients who want to avoid removing the bladder altogether. So many options, many consequences of treatment. So it's very important. I mean, ultimately, especially muscle-invasive disease, it really requires you sitting down with the patient for 20, 30 minutes discussing the potential benefits of the treatment, potential harms of the treatment, the consequences of picking one or the other. And, ultimately, you got to make that decision by balancing out all the other factors. It's not an easy decision because there's many options, there are side effects, and nothing is perfect. Lastly, what I want to talk to you about is the future of bladder cancer. If you look at bladder cancer and the trajectory of patients diagnosed with bladder cancer, they start usually with hematuria, blood in the urine. And then there's several delays across the process. So by the time a patient develops blood in the urine, to the time actually they decide to seek medical advice, sometimes they go for a year without going to see a doctor for it. So we need to work on that. We need to raise awareness among the public about blood in the urine's honors. You go see a doctor right away. And the doctor's not perfect. If you look at primary care physicians, sometimes the patient comes to the primary care physician, they have blood in the urine urine gets treated as if it's a urinary tract infection for a few months until it finally gets discovered. We did a survey among GPs in Quebec, and approximately 20% of those patients who have blood in the urine, they don't end up referred to urology until it's too late. So we have to work on education on that level as well. And then a few things that we have to work, from urologists to the time they get cysto, from the cysto to the time they get actually a biopsy, from the biopsy until the time we get a CT scan. So there's many different delays that we have to work on, and primarily raising awareness at least can avoid these big delays which happens and we're not aware of, which is a delay from the patients to realize there's not something wrong, that they have to actually go see a doctor, and a delay between the primary care physician to actually refer the patient for a urologist. So in my mind, there's a few other things that we need to improve on. We need to improve on our ability to really predict and differentiate between the pussycats and the tigers. There's many bladder cancers that actually linger on and they become a nuisance and they do not cause any life threat to the patient. But the others, they do. And we're good, but we're not perfect in really differentiating these two animals. I think we need to improve the method of detection and surveying those patients with bladder cancer. Whoever's been to a cystoscopy, yes, cystoscopy may not be painful, but it's not a comfortable test. It would be nice that we can replace this test. Improving therapeutic strategies. We need to optimize our therapeutic strategies to improve patients that are cured. So traditionally, this is what physicians used to do historically. They evaluate the patient, they get a clinical impression, and they treat the patient according to their experience, what's out there in the literature, and their gestalt. But really, the field is moving forward and rapidly into something similar to this. What you need to do is you look at each patient, individualized therapy, looking at the molecular level, the molecular profile of tumors, because each tumor has a specific molecular profile that will identify the level of aggressiveness and the level of life-threateningness for the patient. And a lot of studies are gearing towards that molecular profiling of those bladder tumors to help individualize therapy for the patients. So it's not just enough So not just enough to pick one standard therapy for everyone. No, you need to pick the right therapy to the right patient at the right dose at the right time, and that's a challenge. So a big thing is, why breast cancer is light years ahead of bladder cancer and the other one we call orphan cancers is because there's a lot of research in breast cancer. There's a lot of funding that goes into this disease. So they're advanced. We need to, there's a lot of awareness. Women are very strong advocates of their disease, and they raise a lot of awareness for that. Bladder cancer lacks that. We need to raise awareness, not just among the patients, not just among the primary care physicians, among the public in general, among the government, all these levels. There's a lot of levels that we need to address. And through more research, advancement can get done. But primarily we need more research. We need to raise the level of funding on the government level, on the industry level, on many aspects. That's it. If you have any questions, I don't know if are we late on time? Well, a couple questions, and maybe we can move on to the next.
I'll ask a question. I'm not here as a patient, okay. I'm not here as a patient, but as a guide for a patient. And I find that sometimes diagnosing bladder cancer is harder than you say. He went through emergencies 20 times. He had to urinate blood like Niagara Falls before they decide that he had bladder cancer. Why would the patient wait so long?
That's exactly what we're talking about. Is
Because
the delay, there's two delays that can happen.
The problem is not the GP, regular doctors. The problem is doctors in the urology department. They didn't take it seriously. I went for so many times passing blood that they said, oh, well, we're just going to examine your urine every 3 months. And a week after, I end up in emergency, like passing blood like crazy, and saying, well, they flush up my bladder, they stop the bleeding. I wait for an appointment at urology, and they say, well, we're waiting for CT scans, we're waiting for this, we're waiting for that. A month passed later on, I started urinating blood severely again, and just back in the routine. They keep me in the ER for 18 hours to flush up my bladder so it would stop bleeding. And I see the doctors at the urology department, and they're saying, well, I said, I'm tired of bleeding. Something is wrong, because I'm not going to the bathroom every 20 minutes, and it's not normal and a short amount of fluid. And they say, well, nothing we could do. Well, we let things. And then I hear people saying, well, the moment you have blood, you should get treatment immediately or be aware of it. This is where I hate to say it, angry at. I mean, I like what you said, but someone should go to the hospital at the urology department and tell them the same thing that you're telling us. Maybe they would take it a little bit more serious when people have bleeding. It took over a year.
Oh, yeah.
Over a year. And like I said, I eat like Niagara Falls, blood. I'm bitter, yeah. I'm sorry to say, but I'm bitter.
I would do that too. You're right. There's things that sometimes the impressions are different than what's going on. Sometimes they may have diagnostic impressions, such as urinary tract infection or what have you. I don't know what happened in your case, but there should be a level of awareness that's heightened on every single level to speed up the process, to make sure unnecessary delays are avoided.
But the reason I said this is it's like you say normally general doctors are not aware of this. I understand all that, and that is true. Even the emergency department, I don't expect them to realize it. But the urology department, and the worst part is once I did some research on the internet, the Cancer Society said the same thing like you. And, like the hospitals, I guess, of the urology department where I went, I won't mention the hospital, because, they should be the pamphlets.
If you go back to
Jewish General Hospital. And even now, I have cancer for over 1 year now. And I keep asking How serious is it? Which stage it is? Oh, we don't know until we get the results. Well, when they get the results, we don't know yet. I like to know what stage it is, like you say, and I feel I have a right to know. But now I'm so afraid to speak up that they may tell me to leave.
So you're right. Actually, what's interesting, we looked at this on a province-wide scale. So meaning that we looked at delays at every single level. And you're right, delays happen. We're not, neurologists are not perfect either. I'm not exempting them. But delays happen at every single step of the way. So it's a problem that we need to address, and we're trying to address. We put on guidelines. Now there's a guideline on what we call blood in the urine that's circulated to all neurologists and primary care physicians. But there's only so much you can do. The only thing you can try to do is try to address each step and raise awareness on each step where delays can happen. And I share your frustrations.
Okay, we'll have some questioning afterwards as well, and then of course during the reception later on, we'll have plenty of opportunity to discuss it on a one-on-one basis with Dr. Kassouf. Thank you very much.